Good afternoon, CNY Nation. I'm Dr. Randy Fink, and welcome to Fertility with Fink. Happy to have you here. Everybody is currently being told that we have gone live, and it looks like some people are starting to join us. Hi, we're glad to have you. Fertility with Fink is live every Tuesday afternoon at 4 p.m. Mountain Time, which means at 6 p.m. on the East Coast. And if you're joining me, then that means you're not watching the 6 o'clock news. So that much we appreciate you for. Aisha Timbo, Izita 85, oh gosh, oh, you know what? I can't even say it and move by. But hi, it's nice to see you guys. Happy to have everybody with us here from beautiful Colorado Springs, where I am the clinical director of IVF services at CNY Fertility Colorado. I'm also the medical director at CNY Fertility at the Miami Center of Excellence in Miami, Florida, where we are delighted to be able to participate in monitoring for the program. Hello there. It's so nice to see. Hi from Atlanta. There she is. And it's just good to see everybody here. You know, today I thought we would call, oh gosh, PCO therapist, 12 weeks now. Holy cow, I am so happy to hear that. That makes me just overjoyed. I follow your Instagram page. And by the way, if you're watching on, we've got a couple of different Instagram feeds here. We've got Facebook and YouTube and LinkedIn over here as well. And hi, Gabriel from Texas. Glad to have everybody with us. So, you know, I thought we would call this program today. I wanted to do something a little bit special. And that was going to be, we're going to call it, you know, today is your therapy session. CNY has a wonderful program that's called the Fertile Spirit. And they have a great site on Instagram. I've seen there's all kinds of very inspirational things. And in fact, their director has been a guest of mine here on Fertility with Fink and Friends. And I'd love to have her again sometime. But today I thought we could talk kind of doctor to patient as opposed to you know, person to therapist per se. Not so much of necessarily about feelings, but I do want to hear your feelings. Move Vim, hello from Dallas. Wife gave birth on the 13th, thanks to CNY. Gosh, that's great. And hi to Meg from New York. Glad to see you along here with us. So we're talking about why this is a therapy session. And I thought, you know, it might be a good idea to talk about amongst each other, with me perhaps as your moderator, about those things in your fertility journey that just make you crazy, the things that make you pull your hair out, the things that really bother you, because maybe I have some insight into some of those things. I kind of have to live them day to day vicariously through you. We certainly do care about your well-being, and while Fertile Spirit is a wonderful option, a very affordable option to be able to help yourselves through some of those harder times. Thought it might be nice to talk about some of them here. Additionally, I want to send a special hello to Amber Vence. Hello, Amber. Thank you for sending the greeting. This week's Instagram post on the CNY Instagram that comes courtesy of Brandis Montez, our nurse practitioner here in Colorado, is actually going to feature Amber and her journey through doing what is known as intra-ovarian PRP. PRP is platelet-rich plasma, and that is where we take a tube of your blood and separate out your body's what we call your tissue components, your healing components, tissue factors, your growth factors, the most healing parts of your body. And we're able to separate them from the rest of the blood and place them back in places inside of you that can make a difference, in this case, inside the ovary. This is still considered to be an experimental treatment, but we have seen some really great results with it. The data on it is mixed. There are some studies that show that there is a substantial difference in what happens to those who have diminished ovarian reserve and those with egg quality issues. Amber did it today and said it was wonderful and feeling great and can't wait to see the video. So that's going to come out on Friday at 9 a.m. Mountain Time, where we chronicle Amber's journey and show you a little bit about what goes on behind the scenes with intra-ovarian PRP. So look forward to that. And if you've got anything that you want to talk about today, what makes you crazy? What is it about this process that you really wish that you could change? If you follow my Instagram, I've asked that question before. I've had some good answers and heard a lot of things from people. One question Christina's asking, can you do PRP if you are Rh negative? The answer is yes, no contraindication. We're basically taking your body's own tissue and placing it back inside of you. We also use PRP to treat the lining of the uterus. So sometimes we'll do this for folks who have a difficult time getting that lining to thicken. They use PRP in the face for facial aesthetics. They use it to regrow hair. They can use it in damaged joints. So lots of places PRP can be used, but since it's your own tissue, the fact being Rh negative is not a contraindication. So what else to know here? What makes you crazy? What do you wish you could change? The first thing that I learned that seems to be a major stressor to our patients, as if there aren't enough stressors in this process, is the weight. It's the weight, all the different weights. Maybe it's the weight in getting started with a fertility treatment process. It's the weight during the stimulation portion of the cycle to wonder what you're going to get as a result. It's after doing a transfer. It's the wait for the cursed pregnancy test. And I think the unsolicited advice is tough. Just relax or get drunk and it will happen. Yeah, people who don't go through the process and who aren't dealing with what you're dealing with don't understand what it is. And that sort of helpful advice that comes from your friends and family members is often not so helpful, is it? Just relax, and it'll happen on its own. Well, I know a lot of people have been relaxing for years and it still hasn't happened on its own. I wish I could change the insurance policy because I think everyone should have coverage. That's one less thing to stress about. I have to agree with you there. In certain places, there are mandates. There are certain states that have IVF mandates that IVF has to be covered by insurance. So in Colorado, for instance, that has recently taken effect. And I think that's a wonderful thing because I think insurance should have to cover it. Insurance often covers Viagra for men. So why shouldn't it cover treatments, fertility treatments in women? For example, I just got, or I saw a notification that someone had, I believe, placed on the Instagram that they had the VA insurance and that the VA insurance would only cover their IVF if it was if there was a male factor involved, which seems to me to be so outlandishly sexist and gender biased that it's shocking to me that that's still a rule. Well, I got to tell you, that is one of the reasons that I came to work here, because the pricing structure at CNY Fertility really makes IVF available to everyone. It should not be something that is only for the uber wealthy. And I will tell you, I do consultations every single day with folks who are who have maybe had a consult with their local IVF clinic and got priced out that it's going to be $25,000 to $30,000 per cycle of IVF, plus the costs of medications. And if that's not enough to create a stressor in you, then I just don't know what is. So I'm so happy that we can provide this service to everyone. And thanks to my friend Lauren in Miami, monitoring is tough. Grateful to the Miami Center of Excellence. Why, thank you very much. We're very happy to help. If you are in South Florida, then that is a great place to be monitored. And monitoring is a difficult thing as well. Why? It should be so easy, right? But it just isn't. Part of the problem that I see from my perspective is people have monitoring done sometimes in their own doctor's office, which is great, or at some local imaging facility or at their local hospital. And then that facility will not send the results to us for days. Or maybe we might not ever even get the results, or that the laboratory doesn't turn around the results in an expedient manner. It's days before we get that. That is a very frustrating problem. And so I sure like to think that if you can do monitoring in one of our CNY facilities, I think you are better off. Now, not that we can't monitor you globally, because we certainly can. The whole network is set up to do that. But when the results from your cycle monitoring go directly into our system, that creates a much easier system for us to be able to follow you and to make the changes that we need to. I appreciate that, Lauren, that monitoring is a very difficult part. And Shauna says the unknown absolutely drives me crazy. I just wish we knew what we needed in order to be successful. And oh my gosh, that is so true. And, part of the problem that we face as providers is that we want every cycle to be successful. So, we do absolutely our best to try to get you pregnant, because that's what makes us feel good. It's being successful, but sometimes it eludes us, and it eludes us for reasons that we may not even be able to understand. I talked with a very kind patient last week who had a situation here where she triggered her she had about 18 follicles in the ovary. She triggered, and when it came time for retrieval, there were no eggs at all. And the first thing we think about in that situation is, was there something wrong with the trigger? Did the trigger shot not get the ovaries to release the egg? But at the end of the day, there's no way that we're going to know. We're not ever going to get the answer to what happened in that situation. And that's sort of just like the moniker of unexplained infertility. Could you be any more insulting by telling someone that they have unexplained infertility? The gesture I would like to use is one with my hand to show you my feeling about that term, unexplained infertility. But, we don't really know what that means, and we just don't always have the answers. And that's a very frustrating thing to us. But what we do have is the science. What we do have is the wherewithal, the technology, and the people to try to overcome some of those unknowns to be able to help you on your journey to get you where you want to be with your family. Let's see. Chasing for results certainly adds more stress. Monitoring at different fertility clinics can be difficult. You feel like you're at their mercy, and it's chase the results. The Kirsten says here, and that came from Hannah. Kirsten says the unknown, the waiting, the insurance, the feeling left behind, the angry that my body had to go through cancer, which hurt my fertility. Well, I think that is certainly a realistic concern, that having to undergo cancer is something that's very hard to explain. It's very hard to understand why the universe would let that sort of thing happen to you and then have that affect your fertility. But Kirsten, you said something interesting there that I'd like to say a little more about, and that's that feeling of being left behind. What does that feel like to you, the feeling of being left behind? Is that life is going on, that you're aging and you're not yet having a baby? Is that what being left behind means? The feeling of being left behind is kind of a universal human phenomenon when we We feel like things are happening in our world that we are not a part of. And that actually comes from our childhoods. And that's when you're told as a kid, it's time to go to bed. You have to go to bed while others are staying up and watching TV or doing something. And it is a really a primal, hardwired fear that you are going to miss something. And I think that probably goes back even to our caveman origins, where if you went to sleep and something happened that might have affected the longevity, let's say, of your group of people, or the rival gang came in while you were asleep and stole your food. This is something that really is hardwired in us. It's that feeling of potentially missing out. I feel that way too. I think people who are going through fertility treatments, in particular, these stressors become more acute, but can happen to anybody at any time. Couple of questions over here. Is myo-inositol okay to take, even if you don't have any fertility issues? And if doing reciprocal IVF, which partner should take the supplement? So myo-inositol is particularly useful in polycystic ovarian syndrome, and I don't see any harm for either of you to take it. It helps to regulate some insulin resistance issues and some ovulation issues. Those things in turn affect egg quality and implantation. So I think it's probably helpful really to both of you. And certainly I don't think it would be harmful to either one of you. How soon after a laparoscopic surgery to remove fibroids can you start IVF? That's a very good question too. Well, the goal of IVF, of course, is to get eggs, to make embryos, and to hopefully maximize the opportunity with those embryos by putting one in and hoping that it will stick. So I would say if you've had a laparoscopic myomectomy, and a myomectomy is removing a fibroid, you can really proceed in the next cycle with retrieving eggs. In fact, I would often recommend that if we find that you have a fibroid that needs to be removed, that we think about getting the eggs first. And the reason for that is because the younger you are when we get the eggs from you, the greater the probability that we will have better egg quality. So I would say get the eggs, make the embryos, and then worry about the fibroid, because once those embryos are on ice, we can get you pregnant at whatever point. Fix the uterus after you've got the eggs and the embryos. But if you've already had the myomectomy, certainly I think it's fine to proceed with the IVF process even in the next cycle, as long as you feel up to it. But I wouldn't necessarily transfer an embryo into your uterus until the uterus itself is healed. So in that situation, it really depends on how in-depth the removal was, how much tissue in the uterus was affected by that. And it's typically 3 to 6 months before the uterus itself is ready to sustain a pregnancy after removing the fibroid. So getting the eggs, making the embryos is one thing, but putting the embryos back after that myomectomy, you want to give it a chance to let your uterus heal. I want to say a special shout out to Ria. Thank you for being here, Ria, down in Pueblo, Colorado, who says, Dr. Fink, you make this journey much better. And gosh, I do appreciate that. That is a beautiful sentiment. And you are a beautiful soul, and we're glad to have you as part of our family, sincerely. And thank you, Shauna, as well. When priming with Omnitrope, are we supposed to be doing the inflammation protocol with Claritin, Benadryl, et cetera? Does that start with the stimulation? So the antihistamine protocol is part of our really is part and parcel to really all of our immune protocols. And I would say no, the use of the antihistamine protocol is really probably better used when you are actually in the treatment cycle. The Omnitrope being used beforehand is a priming mechanism whose job it is to make either the ovaries or the uterus a better place for eggs or eventually for pregnancy. So that's how we use priming. There's some other things that we can use for priming as well. Estrogen we use for priming, low-dose naltrexone we use for priming. We sometimes use some different supplements for priming. Metformin is a common drug that's used for priming because it improves egg quality. And that's a good thing as well. So hopefully that answered the question there. Let's see what else is on your mind here. Planning, Kylie says, planning life around fertility treatments and then seeing the other people get pregnant without trying. I have to say that truly is a stressor, isn't it? Well, and why? I think, because it's supposed to be easy, right? Pregnancy is supposed to just happen. And when it doesn't, it creates stresses on a relationship for sure. It creates stresses on our own self-esteem and our own kind of vulnerabilities. It brings our own vulnerabilities to light. It brings issues about shame from things that have happened to us before seem to kind of float to the surface. And all these questions in our mind about, is this happening to me because of something that I did a long time ago? I've had people ask me before, you know what? I know I wasn't supposed to do it. I know I wasn't, but I couldn't help it. When I was in high school 10 years ago, I smoked a cigarette. Is that what's causing my fertility problems now? And you may laugh at that because it sounds somewhat ridiculous that there's a lot of things in life that we do other than smoking one cigarette 10 years ago that we can attribute to things happening to us. And no, that's not what happened. All kinds of things in our past. Shame is a very powerful motivator to the human condition. And it's something that we all need to probably be a little better at learning to get rid of. How do we get rid of shame? Well, I mean, that's an easier said than done thing, but it's accepting ourselves for who we are and understanding that even when we're giving ourselves that message that we're broken, that I'm not getting pregnant, so something must be wrong with me. This process hurts, and obviously I must deserve it because of something that I did. It's taking messages like that and really frankly putting them in a bubble and watching them disappear, because that kind of self-talk is really not helpful. We are all inclined to talk that way to ourselves sometimes, but being kind to ourselves, I think, is one of the hardest lessons in this life to learn. It's something that I constantly struggle with, every single day, and that's without these stressors of fertility. So, if that's something that resonates with you, I hope you'll keep it in mind that you certainly aren't alone. The other thing Kylie said there is planning your life around fertility treatments, because God knows this is a labor-intensive process, so to speak, labor-intensive, and certainly making plans around travel. I think probably, to my mind, for most of our patients who come from faraway places here to us, at least in Colorado. We love to see the out-of-towners here because I think this is such a wonderful place to visit. And I love knowing that there may be some little thing that our staff here can do to try to make this process a little bit more gentle, a little bit less stressful, full of a little bit more love, a little bit more caring, so that when you leave here, you feel like maybe not only did you deposit an egg and get an embryo and maybe even have a wonderful parting gift inside your uterus, but also some people who really truly care about you in a process that sometimes can make you feel like nobody cares except for you. So when folks from out of town come here, I marvel at how people can make the logistics work out, because you may not be told until 3 days before when your trigger is going to be. And oh my gosh, you need to be in Syracuse in 3 days. And you say, but I live in Orlando. I have to get to, well, at least Orlando is an easy airport to fly in and out of. You have to be in Albany. You have to be in Colorado. That to me is a very stressful thing. It stresses me out on your behalf. So I certainly understand that. Let's see what we have here. Oh, my friend Judy is watching from Miami. Hi, Judy. Kristen tells us that your frozen embryo transfer was not successful, even though the lining was fine and the levels were optimal on the full medicated cycle. What about boosters and Plaquenil and Prograf? And these are good questions. You know, as we progressively have cycles that are not successful, we start thinking, well, could the immune system have something to do with that? And that's the reason that we add our immune protocols to people's cycles. The immune protocols are designed to suppress some of that immune response so that perhaps your body doesn't treat your incoming embryo like it's an invader. So yes, I think that Prograf, which is an anti-rejection drug, is a useful thing to do in frozen embryo transfer cycles. HCG boosters are very useful in people who have done natural or modified natural cycles. Now, we do offer them even in medicated cycles, and really honestly, a year ago, every cycle was medicated. There was hardly any such thing as a modified natural cycle. The HCG booster is really more useful in the natural cycle, but it certainly doesn't harm anything in the medicated cycle. And what it's doing is that it is your body is going to treat it like more progesterone. And progesterone progestation, that's the hormone that's used to help to maintain the pregnancy inside the uterus. The estrogen builds up the uterine lining. The progesterone organizes that lining and tells it to be ready and to maintain the pregnancy. So that's what the HCG boosters do. I think, yes, it's definitely, Kirsten, worth increasing the immune protocol. Hi, Sally from Trinidad. So see, we are live in our CNY Nation, coast to coast, but also internationally via internet. So it's great to have everybody with us. Let's see, it's almost 30 minutes past the hour. So we'll be able to go for about another half hour. I wanted to call this our therapy session so that you could talk to your friends and to me about the things that drive you crazy, the things that are really the most difficult for you emotionally, personally, in this fertility journey, or other issues of and pertaining to women's health. And I got a note by email I want to mention because I think it's a very important thing. But let me get a quick question here from Katie. And Katie says, is Clomid or Letrozole more effective when trying to conceive? Is one better than the other? So both those medications, Katie, are used for ovulation induction. It's to make sure that your ovary will release an egg so that we can try to get a sperm to go inside to where that egg is going to be at just the right time to maximize the opportunity that sperm will be able to meet egg. They work in different ways. So Clomid blocks, or clomiphene is the generic for that, blocks the receptors for estrogen. And when your estrogen receptors are blocked, your brain says, oh, wait a minute, need more estrogen. Well, if the receptors are not receiving the signal, it must be because we don't have enough estrogen. So brain says we need to make more. How do we make more? You make a follicle, and that follicle has cells that surround it. There's an egg on the inside, but the follicle itself, the granulosa cells in that follicle, are what make your estrogen. So that's how clomiphene works. Femara or letrozole works by blocking the conversion of testosterone to estrogen. Everybody has testosterone in their bodies, both men and women. And in a woman, when we block the normal conversion of testosterone to estrogen, which is a sort of a reaction that happens all the time, whether you're conscious of it or not, estrogen levels will go down. And when estrogen levels go down, the brain says, need more estrogen. And if you need more estrogen, how do you make more estrogen? Same thing. You increase your production of FSH, follicle stimulating hormone. What does follicle stimulating hormone do? It stimulates follicles. Did you get that? Yeah. It stimulates the follicles, and it's the follicles that make the estrogen. So both of those are reasonable options for ovulation induction. But I will tell you that we tend to use more letrozole than we do clomiphene, because clomiphene, as it's blocking the receptors, can have a negative effect on the uterine lining. So the lining of the uterus needs estrogen in order to be able to grow. And in order to be able to grow, you got to have the estrogen. And if you're blocking your estrogen, it may affect the way that lining grows. Clomiphene, much more so than letrozole. So we tend to use more letrozole for ovulation induction. So that's what those two drugs are all about. This came from, an email came from Tony, who says that the thing that bothers me the most is having to feel I have to give away my dignity. Well, you know, that is an important thing. I will tell you that it is also probably the human condition. None of us really like to go to the doctor, especially when it involves things of a personal nature. And when we're talking about fertility and have to, in a manner of speaking, spread our personal selves, open our personal selves to be examined, to be explored, can feel like it lacks some dignity. There are a lot of pelvic ultrasounds. There are a lot of blood tests. There are a lot of things involving the genitals, ejaculation, the preparation of sperm for our male partners, all kinds of indignities that go into this process. And I will say, yes, indeed, Tony, that is a very important consideration. It's something that we as providers try to take into account every time we see you. And that may mean not throwing the cover off of you in order to perform the pelvic ultrasound. There's no reason to even be uncovered. The ultrasound can go in without really even having to look. Once we're pregnant, as I'm sure any of you who have been pregnant or who have had babies before can tell you, that you start to lose some of that, some of those inhibitions. And I think it probably has to do with the process of labor and delivery, in which we're all very exposed, both physically and emotionally. But I will say that one of the nuances of care that we can try to provide in gynecology, and certainly in the fertility world, is to be conscious of our own intimacies, and to help others feel comfortable in being able to talk about and to show us these important, very personal things in their lives. And of course, fertility is a very important personal thing, and even just talking about it is not something that most people do in public conversation. And I think, unfortunately, that leads us to feel alone when we're dealing with some of these fertility issues, that maybe we don't have the support of our friends or our family who really can understand exactly what it is that we have to go through as we're headed down on this journey. So thanks, Tony, for that. Felicia asks, is the HCG a booster or is it just for trigger? Well, that's a good question, my friend, because they're two different things. And hi, Bree is having a transfer tomorrow in Colorado. We'll look forward to seeing you here. HCG can be used as a trigger. HCG functions in the body as the luteinizing hormone, or LH. So when we give you LH, that causes what your body would interpret as an LH surge. And the LH surge is what makes you ovulate. So we use HCG as a trigger. Sometimes we also use Lupron as a trigger, but HCG can also be used in two other ways in our IVF world. One, it can be used as an HCG booster for after transfer. And after transfer, the HCG booster is a low dose of the pregnancy hormone that you give yourself on a daily basis. And as I said, that functions as some LH in the body and ultimately results in creating more progesterone. And the other place we use low dose HCG is as the LH hormone in our stimulation. So when we're doing IVF, there are two hormones that we treat. One is the FSH hormone, because follicle stimulating hormone we need in order to build follicles. That's how we get those follicles in the ovaries to grow, and how we ultimately go and to retrieve them. You may know that there are one of two other medications that we'll use along with either your Follistim or your Gonal F. Follistim and Gonal F are both forms of FSH. They really function the same. There's a little bit of difference with the delivery device, the pen that's used versus the syringe. Some of us are partial to one over the other, but oftentimes it depends on which pharmacy you're going to fill your meds in, because they are often affiliated with one particular pharmaceutical company. So it all ultimately kind of comes back down to cost, because many times the pharmacies can package a bunch of drugs together and give them to you at a less expensive cost, but it may be that you get Follistim versus Gonal F. Well, the other medication is LH, or HCG, or what we call HCG LH. We often use the HCG because it is a much less expensive option than the other medical option, which is a drug called Menopur. And if you remember, I think it was last week we talked about Menopur. Menopur came from the urine of postmenopausal nuns in Italy. And yes, that's true. So I had someone ask me, is that really a true story? Because that sounds like a myth. 100%. 100%. The nuns in the convents in Italy were only too happy to be able to help with helping the world procreate. And so there was really an endless supply of urine in which there was very high levels of the FSH hormone in women who are after the menopause. And so that's where Menopur came from. Menopur is a great drug. It's just more expensive than HCG. But those are the three places that we use HCG. We use it for trigger, we use it for LH, and we also use it for HCG boosters. Good question there, Felicia. What else we got here? Let's see. Is it true that you can have as much progesterone in your body for a frozen embryo transfer, or is there such a thing as a level that is too high? You know, a great question. That one also comes from Kirsten. Kirsten, you are asking some good questions today, sister. There really is no progesterone level that has been shown to be too high. And it's something that we hear about a lot because we check people's progesterone levels. Now, when we're checking progesterone levels around the time of transfer, really what we're testing is testing how much of the progesterone in oil shot is being absorbed. You're familiar, of course, with the progesterone in oil shot. My friend Lauren in Miami sent me a wonderful little cartoon that said, first comes love, then comes marriage, then comes shots of PIO in the butt. So it is our least favorite injection. Doesn't feel good, but it's definitely worthwhile because the outcomes for IVF are significantly improved when we use the shot. We often add vaginal progesterone, which has a local effect in the lining of the uterus, and sometimes even oral progesterone. But higher doses of oral progesterone can be hard to tolerate because natural progesterone has a sedative effect, so it can make you sleepy, and that's why normally we tell you to take that progesterone at night when you go to bed. But the progesterone in oil is really the best way to go, and the progesterone level sometimes does get high. There is such a thing for sure as a progesterone level that is too low, but thus far the evidence does not show us that there is a progesterone level too high that should be any cause for concern. Now, I will tell you, you can look at the internet and you can read, as I've said before, the internet is the world's biggest bathroom wall. You can read all kinds of things on the internet that may or may not be true, but thus far the evidence tells us that progesterone that's too high should not be a problem. Erica is asking about sperm issues, and that's a good question too. Do we treat males in the clinic here? Well, so there is a special type of urologist who will generally handle male infertility. In Colorado Springs, we have a doctor who we refer to here locally, who does not work for CNY, who handles all of our male infertility issues. In New York, Dr. Trussell is available and does see patients in the CNY facility. So if there's issues such as azospermia, meaning to say that there is no sperm in a semen analysis, then that is something that we can help you with, either by referral to Dr. McBride is his name here in Colorado Springs, or to Dr. Trussell in New York. One comment I have to say for those of you who can't see it, again, my friend Lauren in Miami, still traumatized by the amount of urine I've injected myself with. Think about it this way: it's a surefire entrance into heaven, or at least into the bathroom. To be honest, I don't know if it's still made that way. I don't know that they release that information, but at least when it was originally manufactured, that is where it came from. But you know what, Lauren? I think you could probably use a little extra nun's urine, just saying, as and maybe the rest of us as well. Hi to Jody Hoffman, who is our nurse manager here in Colorado. Let's see. We are asked, is there a maximum endometrial thickness for a fresh transfer? And I would say no, not necessarily, not a maximum. There certainly is a minimum, but a maximum number doesn't necessarily exist. But the thing that worries me there is that there are many folks who are coming to see us for embryo transfers whose uterine lining has not been thoroughly evaluated. I recommend an evaluation of the uterine cavity at least once a year. How do we evaluate the uterine cavity? We do that either with a saline sonogram, and a saline sonogram is where we place a little straw inside the uterine cavity and place a teaspoon of fluid inside while doing a vaginal ultrasound, and thus can separate the top from the bottom layers of the uterine lining and can see what's in the inside. Some people can develop polyps. Some people have fibroids. Some people can have scar tissue or bands of muscle. Lots of different things that can affect the inside of the uterus. And my feeling is that if we're going to the trouble of making a beautiful, perfect embryo, I want to know that the environment where that embryo is going to go is just as beautiful and just as perfect. So once a year, I think the cavity should be evaluated. And when I see a uterine lining that's very, very thick, the first thing I think about is there a filling defect on what's happening inside? Is there a polyp? Is there something that's causing that lining to be extra thick? But if the cavity has been evaluated and it's normal, there is no lining that's considered specifically to be too thick at the time of transfer. And oh my goodness, is that Eric Brown, the Eric Brown, who says a wonderful venue? And thanks for all you do for patient education and care. And thank you, Eric, for being Eric Brown. Let's see. That's Eric is an old friend. Gosh, how nice to see you here. Do I recommend an HCG wash and or PRP? That comes from Erica on Facebook. Erica, yeah, I do. The HCG wash is where we place a little bit. You know what? I said there were 3 things we do with HCG, and you just busted me there, sister. There is a 4th thing, and that's an HCG wash. It's where we take a little bit of the pregnancy hormone, teaspoon or so, and place it inside the uterine cavity before doing an embryo transfer. Why do we do that? Well, it's the pregnancy hormone. That sounds like a good thing, right? Well, theoretically, what it's doing is that it's upregulating or turning up the volume knob of the lining of the uterus that improves the ability of that lining to kind of be like a baby blanket and to let the embryo implant. It increases the expression of certain proteins that are associated with implantation. So that's what an HCG wash is. The PRP wash, I believe in very strongly, especially for folks who've had recurrent either implantation failure or that they've had transfers that have been unsuccessful. It's kind of like the most soothing salve we can put on the uterine lining, and that's a PRP wash. And they can usually be done together. They are typically done the day before a transfer. So let's see. What are my thoughts about CoQ10 for both female and male? I would say the answer to that is yes. My thoughts are yes. CoQ10, typically in the form of ubiquinol, is something that we do recommend. It improves both egg quality and is said to have a beneficial effect on sperm. So I would encourage that. Is the carnivore keto diet okay while pregnant? It certainly is okay getting pregnant. I think, this brings up a very interesting point that has to do with weight. And I really wanted, actually, I meant to talk about this. Good nurses always bust their doctors. That's why I'm usually bleeding from the nose at work, Erica. Thanks a lot. And thanks for calling attention to it. Okay. All right. The issue of weight is such an important one because it's something that we all struggle with, and that's one of the things that people often talk to me about. That especially being on some prednisone can sometimes add some weight. The fertility medications can over time affect weight, and we all, or many of us, would like are just very conscious of our body weights and would like to lose a little body fat. That is something that I know people think about all the time. There is no advantage in pregnancy itself for a woman to be losing weight. So we don't encourage weight loss during pregnancy. In fact, we expect to have weight gain because when you think about it, by the time you're at term, you've got, let's call it an 8-pound baby. You've got probably 5 pounds of placenta. Your uterus itself has probably 10 times its normal size. Your blood volume has doubled. Each breast may be 10 times bigger than what it was at the start. So you've got a lot more tissue there. There's a lot more fluid. There's a lot of baby. You've got skeleton. You've got, everything else that's going on. So we do expect we do expect weight gain. And in fact, low weight gain in pregnancy is a cause for concern because it can be associated with fetal malnutrition. Folks who are heavier to start with, we would like to be able to lose, we'd like to be able to gain less weight than folks who at the start are of normal weight or who are underweight. So everyone's going to gain something, and that's okay. Is it a benefit to lose weight before getting pregnant? Well, folks who are heavier in pregnancy do have some increased risks associated with the pregnancy. They are at an increased risk for gestational diabetes, which can have a long-term effect on the baby. They're at risk for some other cardiovascular complications, for wound complications, increased risk for delivery complications. And it's harder to lose that weight after we have the baby. There is some evidence that using the medication semaglutide, or what's called a GLP-1 agonist. So there's a lot of publicity out there now for Wegovy and Ozempic, these medications. Because they are very beneficial for weight loss. Wegovy is approved for weight loss in those who are overweight or obese, whereas Ozempic is approved specifically for type 2 diabetes. We will prescribe semaglutide through my other practice, which is called Cheyenne Mountain Gynecology, and we're happy to consult with you remotely if you're out of town on this medication for weight loss. There is some evidence that shows that it improves implantation rates in those who are at a body mass index of greater than 35. So it's certainly something to think about, but it is not a medication that we use during pregnancy. And in fact, the current recommendation is that you stop it probably at least 2 months before getting pregnant, because it does take some time for that medication to get out of the body. It's a once weekly injectable medication that seems to be very effective at weight loss with minimal side effects. Typically, it can cause a little nausea. It can cause some constipation, but it seems to be very, very well tolerated. Are we supposed to take the PIO at night with all my transfers? I've done it in the morning. The PIO can be taken in the morning. If you're taking oral progesterone, we typically recommend you take that at night because oral progesterone makes you sleepy. PIO does not have the same metabolite that causes that kind of sedation. Lindsay asks, my husband has borderline morphology, talking about sperm here, and we're starting our IVF cycle with CNY tomorrow. Lindsay, that's awesome. What are your thoughts on Zymot? Could that help with the morphology issue? So when we talk about sperm morphology, what that means is that someone's job is to sit at a microscope and look at sperm and tell us whether they're normal. They have a head, they have a neck, they have a tail. Sometimes they have two tails. Sometimes they have a crooked neck. Someone studied a very long time to look at sperm and to be judge and jury on what the sperm look like. They are the beauty contest judges for sperm. Think of it that way. However, the issue of morphology is not considered to be a cause of infertility. It may be associated with subfertility. However, morphology is not always reproducible. So morphology means that, well, it's normal that up to 96% of the sperm can look abnormal. And gosh, 96% abnormal is normal. So that's probably why it's not considered to be a cause of infertility per se, but rather is associated with subfertility. So how many people out there have abnormal morphology but don't have a difficult time getting pregnant because we never test their sperm because there's no reason to, Zymot is a way of theoretically separating out sperm that are better swimmers and that may potentially be more normal. It's an add-on at CNY. It cost, I believe, it was $200. That pricing may have changed a little bit. Could it help you? Yes, I think it could. Does it help everyone? No, I don't think it does. Is it harmful? Well, as long as there is sufficient sperm count, as long as there's enough motile or swimming sperm, then Zymot is not harmful. And it costs $200. It's not $2,000. And so maybe it is a good thing, especially in your situation where morphology was a concern. Ashlyn is asking, can we freeze some eggs on day 3 and push the rest to day 5? Struggling on what to do. We don't recommend that you do that, Ashlyn. In fact, we kind of need a plan that it's either day 3 or at blast. And so typically what we say, if you have 5 or more embryos, we recommend that you grow them to the blastocyst stage. If you have 4 or fewer, we recommend that you do something with them, either freeze them or transfer on day 3. Ashlyn says, I have endometriosis and a low AMH, so skipping PGT since we won't get many eggs. Well, in your situation, Ashlyn, I would say I think it's a much better thing to have an embryo to go back inside of you on day 3. We would much rather see an embryo in you than an embryo that potentially doesn't grow in the lab. I like to refer to it as the magic sauce. You may have the magic sauce in your uterus that we don't have in the lab. And so that embryo that might not have grown in the lab and might have died and had to be discarded might grow inside of you. So there is nothing wrong with the day 3 embryo. We know that the blastocyst has a greater probability of getting you a baby, but that doesn't mean that a day 3 embryo cannot get you a baby. So if in doubt, get it in you for day 3. Now, fresh versus frozen, the frozen embryo transfer is always going to have a higher success rate than a fresh transfer, but people do get pregnant from fresh transfers every single day. So fresh transfers are included in the price. If you can do it, go ahead and do it. Lindsay says, my AMH was very high at 19.4. So that's typically consistent with polycystic ovarian syndrome, or ovaries that are going to respond very well. They typically pay very good attention to the medication. Anything that you can do to help prevent ovarian hyperstimulation? Well, one, we would want to lower your medication protocol. We would want to decrease the amount that you're on to increase the probability that you don't end up with OHSS, because we really want quality over quantity in terms of those eggs. Extra protein during the stimulation is another thing that you can do that can help prevent OHSS. And OHSS would be another good topic for us to talk about next time. I appreciate everybody who has chimed in with all those things, the therapy things, the things that bother us the most about what you have had to go through. I want you to know we are all on your side. We all want this to work. I wish I had the opportunity to be able to talk to everybody personally here. We're kind of running out of time, about a minute or so left. This is Fertility with Fink and Sometimes Friends. Next week, we will have Ryan Rolla, one of our nurse anesthetists here in the studio, to talk about your anesthesia with your procedure, to answer all your questions about that. But in the meanwhile, let me just say I appreciate the privilege of being able to be here with you tonight, and for everything that we are able to do for you and your family at CNY Fertility. If we can be of service, please do reach out. In the meanwhile, God bless all of you. Thanks so much for being here, and good night.